Good afternoon, everyone. So today we're going to discuss about hypothyroidism. So to know about hypothyroidism, first we'll see how the thyroid gland is functioning. So for that, so we all know this is hypothalamus. This is the anterior pituitary and this is the thyroid gland. So basically, the hypothalamus will produce TRH. What is TRH? Wrong. No. What is TRH? Yes, it is thyrotropin releasing hormone. So there are thyrotropin receptors present in anterior pituitary. So this TRH will go stimulate those receptors, which in turn will release TSH. So what is TSH? Yeah, it is a thyroid stimulating hormone. So this one will go there are receptors present on the thyroid gland. It will go and reach the receptors, which in turn will produce T3 and T4. So T3 and T4. So can you tell me which among this is more active? Which? Yeah, which is more abundant? Yeah, so T4 is present in large amount. That is, T4 is present in large amount, and T3 is more active form of thyroid hormone. So there is this feedback mechanism which is present. So if there is increased levels of T3 and T4, it sends a negative feedback. So which in turn will inhibit the production of TRH and TSH. So even if the same thing is applicable, negative feedback is the same when it is like low levels of T3 and T4. So when there are low levels of T3, T4, it again it stimulates the TRH and TSH production from the hypothalamus and anterior pituitary gland. So there are primary, secondary and tertiary hypothyroidism. So primary hypothyroidism is mainly caused by the gland itself. Secondary hypothyroidism is any problem in the anterior pituitary gland. If there is a problem in the hypothalamus, then that is the tertiary hypothyroidism. So if you see in primary hypothyroidism, majorly there is we are just seeing about the low levels. So in primary hypothyroidism, there is T3 and T4 low levels, whereas TSH is high. That is primary. In secondary hypothyroidism, TSH is low. That is the gland itself. That is anterior pituitary is not able to produce the TSH. So it is like low TSH. Because automatically if there is low TSH, there is low T3 and T4. So that's why there is hypothyroidism. Again, tertiary hypothyroidism is caused when hypothalamus is not able to produce TRH. So when low TRH, low TSH and as well as low T3, T4. So coming to the causes, so autoimmune, there are when the body produces our own antibody, attacking cells like for thyroid. So autoimmune disease, so majorly one particular autoimmune disease for hypothyroidism, Hashimoto's disease. So where the own body produces antibodies against the gland. Then coming to surgical, if the gland itself is not there, if there is any removal of the gland because of any malignancy or something, so that time it causes hypothyroidism. They require a hormone replacement therapy. Radiation. So radiation, when there is any radiation, you're exposed to radiation for a long period of time, there is damage of thyroid cells. So because of that, there is possibilities of hypothyroidism. Then congenital, if the person is by birth is having a thyroid disease. Certain medications also causes hypothyroidism. Anyone know any one of the medications which causes hypothyroidism? So there are four most known which causes hypothyroidism. So one is lithium, which amiodarone, then interferon alpha and interleukins 2. So all this causes hypothyroidism. Then thyroiditis, that is inflammation of the thyroid gland, also causes low production of thyroid hormones. So there are certain functions of the thyroid hormones. It increases the basal metabolic rate. So what is metabolic rate? So basically this thyroid hormone will help in catabolism of protein, fats. Okay, yeah, it helps in catabolism of protein, fats and glycogen. Yes. So all these three. So what happens is you have increased metabolic rate when you have high thyroid. Then brain development, usually thyroid is more important in brain development of it acts on the nerves. So there is less IQ if you have thyroid. So this is majorly seen in fetal stage. So congenital hypothyroidism also is if mother is passing, so genes that also can cause. And if mother is baby is genetically having hypothyroid, that will cause low brain development. Then GI motility, then hydration, then bone growth, muscular system function and development also, so normal cardiac output, and ovarian cycle and spermatogenesis. So when we see the functions, symptoms are straight opposite to that. That is, if you have increased metabolic, if the function is increased metabolic rate, obviously, so when there is low metabolic metabolism in the body, there is increased fat, proteins, everything, so which in turn leads to weight gain. Then brain development, you'll have low IQ. Then even memory, in adult patient who's having hypothyroidism, you can see even memory is impaired in those patients. Then GI motility, because there is reduction in GI motility, it causes constipation. Hydration, it helps in hydration. So obviously the problem is dry skin. Then you see bone mineral density is reduced in hypothyroidism patient, because it is helpful in musculoskeletal thing. You will feel like lethargy and all that. Then you see bradycardia, and it also affects the menstrual cycle and all that in women. So for diagnosis, diagnosing, first test that you have to do is TSH. So if TSH is low, if TSH is elevated, that shows it is a hypothyroidism. Because if it is a primary hypothyroidism, what happens is there is low T3, T4, but this sends a negative feedback, as you know, because there is low T3, T4, it sends a negative feedback, and it will be like you have to produce more hormones. So this hypothalamus will stimulate constantly the pituitary gland to produce TSH. So if you see in hypothyroidism, TSH will be more and T3, T4 will be less. That is in primary hypothyroidism. In secondary hypothyroidism, what happens is TSH itself is low. So if TSH itself is low and T3, T4 also will be low, so this one also causes hypothyroidism. Then if TSH is low even in terms of hyperthyroidism, that time even T3 and T4 will be high. Okay, so this is for distinguishing the hyper and hypothyroidism. Okay, that is in secondary hypothyroidism, TSH, T3, T4 both will be low, but in hyperthyroidism this one will be high and TSH will be low. Then coming so when you're doing TSH, if there is elevated TSH, you see a low level of T4, then it is a confirmation that is a hypothyroidism. That is a primary hypothyroidism. What is a normal range of TSH?
5.
Sir? It's 0.4 to 4 million units per liter. So when TSH is elevated, that is, it is more than 5. So normal range is 0.4 to 4. So if it is more than 5, that time it is like elevated TSH, and low T4, it is primary hypothyroidism. And if you have normal T4, it is called subclinical hypothyroidism. That means the patient is like, showing the early symptoms of hypothyroidism. Then coming for the treatment. So treatment protocol is basically very, very simple. So if any patient, even with cardiac or renal failure, who is coming, even if it's like elderly, like above 50 or below 50, in pediatrics, it is based on weight. You have to do the dose calculation. It's like 1 mcg per kg is the dosing. But in normal adults, like above 50 kgs or below 50 kgs, it doesn't matter. 50 years, it doesn't matter. So this like starting therapy is 25 to 50 mcg is given once a day. So you give this give this for 4 to 6 weeks. After 6th week, you have to repeat the TSH. Again, if the TSH is still elevated, then in the next setting you have to again increase the dose by 25 mcg. That's how you do the dosing. So you have to do the dosing until you obtain 0.35 to 4 million units per liter. This is the TSH value. So this should be your final TSH you should get. That is the targeted TSH. So till you get this value, you have to do the dose adjustment. So dosing of levothyroxine is this is levothyroxine treatment. So levothyroxine is basically like it starts from 12.5. So 12.5, 25 like that, increase multiples of thing. Then in pregnant women, they require 9 doses a week. That is 2 days they can take 2 doses. That's how you obtain. Why? Because thyroid is very important in women for the menstrual cycle or ovarian health or whatever. So when the woman is pregnant, the requirement of thyroid, because it also acts on the fetus for the development development of fetus. So that time women who is a known case of hypothyroid will require 9 doses in a week. based on her any dose whatever she's taken, she requires 9 doses a week to attain the requirement. Then coming for subclinical, this is for a normal, like if the levels are above thing. So if for subclinical TSH, if the TSH is less than 10, that time you can give 50 mcg OD, and the same thing can, you can follow, like after 6 weeks you do the reassessment of TSH and T4, and then start the therapy again, like add for the present therapy 25 mcg till the attained TSH levels. Whereas if TSH is more than 10, you have to give based on weight. That is 1.6 mcg per kg once a day. This will be the dose calculation if it is less than 10. So now tell me, if the patient is coming and reporting with after 6 weeks, if he is taking 25 mcg and as his regular therapy for, like he's taken for good 6 weeks, and if his repeated TSH is elevated, will you increase the dose or look, okay, he's taking 50 mcg, so will you increase the dose or decrease the dose of the medication that you're giving? T3 T4, like thing, because of TSH elevated only we are giving medication. So in the next setting, if TSH is still elevated, that means you have to increase the dose. If there is less TSH, then again you have to decrease the dose.
That's your primary hypothyroidism, right?
Yeah, for primary hypothyroidism, this will be the dosing. That's how you increase or decrease the dose based on thing. Then anything else?
Why only levothyroxine?
Yeah, so levothyroxine is more convenient. When you're giving dextrothyroxine, what happens is the dosage requirement is more in terms of dextrothyroxine. In levothyroxine, the body is easily adapted to like levothyroxine, so less dosage you can give. In case if you're giving dextrothyroxine, the dosage requirement, like you have to give more. So that's why levothyroxine is preferred over dextrothyroxine. And there is like lot of difference even in pharmacokinetics. So better pharmacokinetics is seen in levothyroxine, like once a day dose and all that is seen in levothyroxine. But whereas dextrothyroxine, there is like you have to take two times a day or 3 times a day. It's like that.
Maximum tolerated dose.
Maximum tolerated dose is 200 mcg. Sorry, 200 mcg is the maximum tolerated. And in pediatrics, you can there is oral like syrup also available for pediatrics. It'll start from 13 mcg for pediatrics. In adults, the starting dose is 12.5 mcg tablets. It goes up to 200 mcg. Okay, this is the maximum doses available for the treatment. Anything else? The ADRs is based on this only. So what happens is, if you have, when you're taking the medication, the symptom is constipation. So sometimes patient experience diarrhea when you're taking the, levothyroxine. And you can see one more thing is,
Weight loss.
yeah, you can see severe weight loss. So all that based on symptoms is the thing. And you will have severe headaches. All these are the major ADRs. Huh?
By how much start the medications?
By
By how much start the medications and the TSH values are?
0.